Welcome to SPMM Revision on Demand. In this podcast, I will discuss the issue of allocation concealment and blinding. Let us first consider the flowchart for an RCT. The difference in the response rate for active and placebo interventions are compared in an RCT. Random allocation enables us to make unbiased comparisons, and so randomization lies at the heart of the RCT. Suppose there are two groups for a trial, A for active treatment and P for placebo. Assume that we need 10 patients for the trial. A random sequence has been generated using a computer. This sequence reads as follows. Suitable subjects who give consent are allocated successively according to the above sequence. What will happen if the clinician or the patient comes to know about the above sequence? Consider that we are at the stage of recruiting the fourth subject for the study. A clinician has just seen a patient who is suitable for the trial, but she may think, this patient seems to be doing poorly. I will rather allocate him to the treatment group. I will wait till we get one more patient recruited before I send him for the trial. An eligible patient who comes to know of the sequence may think, let me wait for a few more weeks before entering the trial. I may get active treatment if I enroll later. At the moment, if I enter the trial, I will only get placebo. As you can see, this will defeat the whole purpose of randomization. So it's very important that the random sequence is concealed and kept secret from both the clinicians and the patients. So from the time of sequence generation to the time of allocation of the treatment, we need the sequence to be kept secret. This is called allocation concealment. This preserves the outcome of randomization. No one can deduce which arm the next patient will go to if the allocation is concealed. This will reduce selection bias. But how is this done? Firstly, the person who generates the allocation sequence should not be the person who recruits or assigns the subjects to the trial. If possible, we must use a centralized or remote randomization service. For example, through a telephone, fax, email, internet, or through a coordinating center or site pharmacy. If the same personnel are involved in generating sequence and assigning the groups, then serially numbered, opaque, sealed envelopes containing the random sequence should be used. This is called as SNOOSE, S-N-O-S-E. So how long should the secret be maintained then? Suppose there are two groups for a trial planned for 6 weeks of treatment period. Group A receives active treatment and B receives placebo. Assume that we have completed the recruitment for the trial and we are in the third week of the trial period. What will happen if the clinician treating the patient comes to know which arm his patient belongs to? She might tend to overreact to side effects seen in those who receive active medications and may in turn downplay the side effects seen in patients who are receiving the placebo. What will happen if the patient comes to know which arm she or he belongs to? He might then tend to report less improvement if they are taking placebo or overrate the improvement if they are receiving the novel active intervention. What will happen if the assessor rating the patient comes to know which arm his patient belongs to? He might tend to overrate positive outcomes in the active treatment group and underrate the ill effects of the treatment in the same group. As you can see, all of this will defeat the whole purpose of randomization. Hence, from the time of allocation until the time of treatment completion as well, we need to keep the group assignment secret. This is called blinding. In single blind trials, either the patient or clinician remains unaware of the treatment assignment. In most cases, single-blind trials keep the patients blind. In double-blind trials, both the patient and the investigator are unaware of the allocated treatment. In triple-blind trials, the patient, the investigator, and those who adjudicate the study outcomes, for example, the assessors, are also unaware of the allocated treatment. Open-label trials have no blinding. As shown here, blinding will reduce measurement bias. This flowchart shows the relationship between allocation concealment and blinding. As you can see, allocation concealment refers to preserving the sequence from the time of generating random sequence till the time of allocating patients to the treatment arms. Blinding follows thereafter. Note that blinding may not be always possible. For example, when you are evaluating psychotherapies, it is very hard to keep a patient blind from knowing whether he or she is receiving CBT or not. Also, even in situations when blinding is practiced, it may not always work well. For example, in a study comparing the efficacy of fish oil capsules versus placebo in reducing depression, patients taking fish oils will experience a fish burp, making it difficult to maintain the integrity of blinding. In contrast, allocation concealment is always possible, and it must always be carried out with 100% integrity in all randomized controlled trials. Now, it's time to ask yourself a few questions. Thank you for choosing SPMM course for your revision. Please note that these video materials are best used in conjunction with our mock exams and online revision materials.